Okay, so let's go ahead and get started. Okay. Thanks for coming, everyone. It's a pleasure to have you all, and thanks for your interest in the clinical care and interventional radiology. I have the pleasure of introducing today Dr. Nitin Egbert. He's an internist who just took his IM boards a couple days ago and will be starting as one of the academic hospitalists at UCSF next month. He'll be talking to us today about the management of hypertension. And so with that, I give the floor to Nitin.
Awesome. Thank you for the introduction, Austin. Pleasure to be here. Thank you all for coming. So hypertension for IRs. I'm actually going to turn off my video here unless I have to explain something detailed to save my bandwidth. I think this is super important, just as you guys are starting to manage your own patients and admit your own patients and everything. Honestly, if I can make more of my job obsolete, I will be super thrilled. And it looks like a lot of you guys are just eager and happy to do that. So let's get into it. Our learning objectives here for this lecture are fairly simple. We're going to do the hard part, reviewing acute inpatient management for hypertension. And I want to get a couple of details here. Differentiate between urgency and emergency. That's probably something you've heard multiple times, right, at this point. Learn blood pressure goals in hypertensive crisis, what exactly to do, and what medications to select on the inpatient side. And once we've talked about the inpatient side, we'll talk about the outpatient management. How to adjust medication doses, when to work up for secondary causes, learning situations where certain common medications are preferred. And in general, my goal here is really to reinforce the basics and give you confidence, because a lot of this stuff is going to be things you guys already know. And it's just going to be details on top of that. So we'll try to derive whatever we need from those details, from the basics, I mean. There will be some practice questions. I'll open up one early on for something, it's a poll everywhere that you can join from your phone or from your computer. And I'll let you know when that is open. But the lecture probably does work best if you are following along and interacting with some of the practice questions and the polls. If you're watching this lecture after the fact, when it's recorded, feel free to pause it at certain points and just see what you'd answer to certain questions. All right, hypertension. So inpatient management of hypertension comes with one crucial question. How high a blood pressure is too high? First of all, there's one thing you should always do when you get called with a blood pressure. You always recheck the vitals, right? A good nurse will frequently have already double checked the blood pressure, but even an experienced attending might sometimes forget to ask, did you recheck that? Is that a second check? Was it high on recheck? And maybe it's fake, maybe it's just the cuff was too small, or the patient flexed while the blood pressure was being taken, and you got a call that's, well, the patient's blood pressure is 180 over 110. I don't know what to do. So always recheck the vitals. But say you recheck the vitals and blood pressure is too high. What is the actual, what does too high mean? Well, it's not a specific number, right? The actual question is there end organ damage? And this is something that's been beaten into our heads from the very beginning of medical education. There's a difference between hypertensive emergency and urgency. If there's end organ damage of any kind, then you usually want to do something about the blood pressure right away. Otherwise, you can do it slowly. And that's your actual question. How high a blood pressure is too high? When there's end organ damage, your blood pressure is too high. So follow-up, and this is our initial question where I'll let you join the poll everywhere. What is the difference between emergency and urgency? What organs should we evaluate for end organ damage? We get a high blood pressure, quote unquote high, it's anything above 160, and the patient is reporting symptoms. What symptoms are we worried about? What organs are we trying to evaluate for damage? So take some time. If you can see this, it's pollev.com/Nitin Egbert 436. You can go to that link or text that number to join. And let me know if that isn't visible on this slide. Awesome. So we've got some answers coming in already. Heart, brain, kidney, lungs. Yes. Yes, these are all important organs, right? And they're all one of the most commonly damaged ones in a hypertensive crisis. So heart, brain, kidneys, lungs, very good. There's one more I'll add there, which is just eyes. But I think the last time many of us did a fundoscopic exam on a patient is an intern year. Do remember the eyes. Hypertensive retinopathy is a thing. And I know some facilities, it's harder than others to get a hold of a fundoscope. And where I trained, you had to go out of your way to get a fundoscope and look into the eyes, but it is important to do. So how are we going to evaluate for end organ damage? Well, first, you're looking for physical exam clues and vital signs or things in the history that are telling you what's going on. So heart symptoms, usually if they have chest pain, diaphoresis, syncope, palpitations, epigastric discomfort even, right? You're gonna start doing tests. You're gonna test tropes, you're gonna test an EKG. Usually bare minimum in a hypertensive urgency, you can get an EKG and nobody's going to fault you for it. You're usually going to get a chest x-ray just to check the large vasculature. You might check a CTA if the presentation sounds suspicious for PE. Lungs, bare minimum, you're going to get a chest x-ray. If they have any shortness of breath or dyspnea on exertion or even a cough, you can get a chest x-ray. Nobody's going to fault you for it. Kidneys, they don't have to have symptoms for kidneys, right? Frequently, you'll see just an AKI. So a lot of times you'll just be drawing a BUN or creatinine if there hasn't been one drawn recently. You can get a urinalysis, you can get electrolytes if you're starting to suspect other things. You can get on the brain, if they have altered mental status or a focal deficit, obviously you're going to start getting brain imaging. Altered mental status, you can still get a non-con CT. Focal deficit of any kind, you're going to immediately get CT stroke protocol or an MRI if you can do it stat. But those are things that are more obvious. You guys will do by default getting an MRI diffusion or a CT perfusion if you need it. Eyes, I'll just reinforce that fundoscopic exam. If you have at all fundoscope accessible, go look for papilledema or ask somebody to do it. If you have like an ophthalmologist, you can curbside for it quickly. Not every facility, I realize, is gonna have a readily available ophthalmologist just waiting for you, but don't forget the eyes. So if there's no end organ damage, what are you checking for? You go through this whole process. You draw some basic labs, you draw creatinine, you get an EKG, you get a chest x-ray, nothing's abnormal, and the patient's totally asymptomatic. So you're not suspecting end organ damage. Well, double check again. Is the blood pressure reading accurate? Just check their blood pressure again now that you've done that process. If it's still high, you're gonna check a couple of basic history things. Do they take blood pressure medication normally? And if they do, is it close to due? Or is it overdue? Did they miss a dose? Those are going to be easy things to fix for just a patient being hypertensive, especially inpatient. Doses get missed or delayed for various reasons. Maybe that's all that's happened. Do they have fluid running? A lot of times fluid gets started on a patient with no end date, or maybe the end date's in the future, and it's still running and they don't need it anymore. Fluid running is going to make them a little bit hypertensive. Their body has extra intravascular volume that they're trying to eliminate. Is the patient in pain? Another super common one, right? Are they nauseous even? If they're in some kind of discomfort, you can correct the discomfort and then recheck the blood pressure, because that might be increasing their blood pressure all by itself. Is the patient anxious? That's another reason, right? Any kind of discomfort. And if there is no end organ damage, you go through this process. There isn't an emergent need for blood pressure lowering. And I really mean that. You can just start oral medications, or you can start scheduled medications. And some hospitalists will let acute blood pressure run up to 180 over 110, as long as it's not fluctuating and you've started a medication, you know it's going to be more controlled. You don't mind, as long as there's no end organ damage. The rapidly fluctuating blood pressure is going to be a thing that comes up a couple times. That's actually worse for the patient. Technically, each new spike in blood pressure, if you're letting them, start at 180, drop to 130, and then go back up to 160, each of those spikes is technically a new event. event where you should be checking for end organ damage. Pain in the neck for you and a pain in the neck for the patient. This is one of the reasons it's good to start oral medications right off the bat, rather than chasing something with PRN medications. Currently, initial choice of medications is another high yield thing because it's going to come up a couple times. If you're starting oral medications, you have chlorthalidone or thiazide diuretics. I don't really like using those inpatient if possible. Amlodipine has great cardiovascular benefit. Lisinopril, which you're going to see a lot just because it's used in anything with kidney disease. It is contraindicated in AKI though, so you're going to have cases where you might not want to start lisinopril. So we'll go to our first practice question here, and we'll just go through a basic scenario here. We have a 68-year-old male, history of hypertension, CKD3, type 2 diabetes, PAD. He developed right shin cellulitis 2 weeks after a contralateral iliac stent, so this is on his other leg, and he's admitted to your service, probably because he's a bounce back. He had a pre-renal AKI resolved with IVF, IV fluids, and his initial blood pressure is negative. You've already started appropriate antibiotics, but nursing calls you and tells you his blood pressure on the last 2 checks, so they rechecked it for you, is above 160. They ask if you can put something in for hypertension. Vitals are listed. Important ones here are blood pressure is 172/92. And nursing reports that the patient's amlodipine was just given, and the patient is reporting 7 out of 10 pain. He's also receiving LR IV at a rate of 75 milliliters an hour. He looks uncomfortable, and he's finishing breakfast. He has blanchable erythema up to the knee, but all other exam signs are normal. What do you want to do with this patient's elevated blood pressure, this nursing call for elevated blood pressure? Do we have to do anything? All right, starting to get a couple results. I'll let a couple more answers trickle in, and then we'll see how the numbers are looking. All right, we got five answers so far. So let's actually take a look at what people are answering. I think everyone's saying the same thing, it looks like so far. That's correct, right? This patient is in discomfort, and we still have IV fluids running from when we were trying to get rid of the AKI. So the first thing to do in this patient is just control the patient's pain and discontinue IV fluids. Then you can recheck the blood pressure. And if it's still absurdly high, then start chasing it. But for now, all you need to do is control the pain and discontinue IV fluids. Very good, guys. Good work. All right, blood pressure goals in emergent hypertension. So say you do get end organ damage. That's what this is talking about. Emergent hypertension is you've gone through the process, the patient's reporting confusion or maybe shortness of breath or chest pain. What do you want to do? What are your blood pressure goals? Well, in most cases, if you have some end organ damage or it's emergent, you have blood pressure goals within the first hour of a 10 to 20% reduction, okay? That's important. You don't want to drop it immediately right away. A lot of people are used to the higher blood pressure, or mostly their cerebral vasculature is used to the higher pressure. You don't want to drop their cerebral perfusion too fast. So usually we only reduce 10 to 20% in the first hour. And then over the next 24 hours, we can reduce it a total of 15 to 35% from the initial presentation. But that 10 to 20% reduction in the first hour is an important goal to have. Unless there's a couple of exceptions here. There's a couple of cases where you don't want that 10 to 20% reduction. There's 3 conditions. The first one is ischemic stroke. And this one you've heard before. Ischemic stroke, we want permissive hypertension. And the reason for this is you really don't want to drop the cerebral perfusion. So you allow people to become hypertensive and even more hypertensive as long as they're maintaining a blood pressure below 220 over 120. If they're going above that, you can start pushing things to control the hypertension. Most of your patients are not going to go that high, but remember permissive hypertension. So if you're getting any focal neurologic signs or aphasia, and you're suspecting that's the end organ damage in your emergent hypertension, don't jump to control the blood pressure because you want it to be high. If there's TPA as well, After TPA, you're going to want 185 over 110. That's to decrease the risk of hemorrhage afterwards. So you do have different goals here in ischemic stroke. The second condition where you don't want that 10 to 20% reduction is hemorrhagic stroke. Here, regardless of how high their blood pressure was, sorry, my slide is lagging here. Regardless of how high their initial blood pressure was, as long as it's under 120 or 220, you're going to lower it all the way to 140. Initial blood pressure is 200, you're going to lower it to 140. And that's to make sure that you're not making the hemorrhage worse. There is actually a caveat here. The study that showed you want to lower it to 120, 140 only studied patients up to 220. So technically it can be a little bit more lax if their blood pressure is higher. Up to date recommends 160. So I usually just keep that recommendation. But generally for hemorrhagic stroke, you want to lower it to 140. The third condition is acute aortic dissection. So for acute aortic dissection, you don't want that 10 to 20% reduction. You want to lower it all the way to a systolic blood pressure of 120, 100 to 120. And you have a heart rate goal, actually, in acute aortic dissection. You want it to be less than 60. And this is purely because a faster heart rate is agitating that intimal flap that forms in that acute aortic dissection more, and it's going to make it propagate more. So we control both blood pressure and heart rate in acute aortic dissection. So these three situations are the only cases where you don't want to just reduce 10 to 20%. So keep those ones in mind. And let's talk about, we have a blood pressure goal. What medications are you going to give to reach that goal? This is the preferred acute antihypertensives. Let's talk about for ischemic stroke. Ischemic stroke, you can actually use pretty much whatever you want. I include this for completeness sake. Some neurologists like this factoid. For very large strokes, there's a theoretical drawback to using hydralazine or nitroglycerin or some of the venous vasodilators because they increase CSF production, increase the intracranial pressure, and also decrease your systemic blood pressure. So they're going to decrease your cerebral perfusion pressure. But in practice, this is almost never applicable. If a neurologist tells you not to do hydralazine, don't use it. I do tend to use labetalol in ischemic stroke if possible, just because I'm afraid of this, but it doesn't bear out in practice. Hemorrhagic stroke. This one actually has a very specific drug that we prefer, and many of you will know nimodipine. It's a calcium channel blocker. Other calcium channel blockers can be used as well, but nimodipine specifically helps prevent vasospasm, and it seems to be associated with an improved long-term functional outcome in patients with subarachnoid hemorrhage, and it doesn't increase the improved functional outcome is actually not a class effect. The other calcium channel blockers don't seem to do it. So nimodipine specifically, if you can start early and you're suspecting hemorrhagic stroke, start it. Aortic dissection also has a very specific drug that is our preferred. Esmolol, it's a beta blocker. And remember I said we're controlling both blood pressure and heart rate. So esmolol accomplishes that. If you can't get a drip started right away, labetalol is just fine too. It's also a beta blocker with some non-specificity. So it'll slow down your heart rate and get your blood pressure. If the first thing you're doing when you're suspecting aortic dissection is just pushing labetalol, you're doing a great job. And I've already kind of explained why, because we're trying to avoid the shearing forces of a rapid heartbeat. And my slides are lagging a little bit again. My apologies. All right, there's some other conditions too where we do have preferred antihypertensives that I'd like you guys to kind of keep in mind. Acute heart failure, if with a hypertensive crisis. Here, I'm going to let you guys think about this a little bit. We want antihypertensives that decrease preload, right? Because it's heart failure. We love decreasing preload in heart failure. So if you can decrease venous return, then we decrease preload. We make the heart failure better at the same time we make the hypertensive crisis better. So the loop diuretics, perfect. The diuretics you're already going to give for the heart failure are going to help you with that hypertensive crisis. Other things you can use are the nitroglycerin and the nitrates. You're going to decrease venous return because you're increasing the vascular volume, and that will also help you with heart failure and help improve inotropy as well. So those are actually our preferred if somebody has an acute heart failure and they have a hypertensive crisis. Avoid hydralazine in this case. because it causes reflex tachycardia, gives the heart less filling time. You can make the heart failure, the cardiac output worse. You also avoid the calcium channel blockers, the dihydropyridine ones specifically, and the beta blockers. And this is because those decrease the inotropy of the heart as well. So you don't want to make the heart failure worse. Beta blockers are specifically, you should only stop them if the patient's not already on them, or rather, you shouldn't start them if the patient's not already on them. If the patient is stable on beta blockers, they've been taking it regularly, and they come into the hospital and they have acute heart failure and they have a hypertensive crisis, leave them on the beta blockers because that beta blockers isn't what's precipitating the heart failure. Beta blocker is good if they're already on it. You just don't want to start one new. One more condition where we do have clear preferred antihypertensive is acute coronary syndrome, or even if you suspect ACS with a hypertensive crisis. Here, you can use nitroglycerin or you can use beta blockers, right? Both of those things make coronary syndrome, ACS, better. And both of those things are things that you start in ACS. Nitroglycerin is going to improve the chest pain, not necessarily have a survival benefit. And metoprolol is going to decrease inotropy again, take the stress off the heart. Here is another situation where we avoid hydralazine, specifically because it causes reflex tachycardia. Tachycardia is bad for coronary, for ACS. You want to do the opposite of tachycardia. All right, so we'll go to our next practice question here. You're consulted by the cardiology service for the retrieval of a malpositioned sentinel device. I've actually seen this one happen before. In the ascending aorta, after the cardiology service has had 2 failed attempts to retrieve it, the patient is a 59-year-old female with a history of aortic stenosis, status post TAVR, which was 2 days ago, hypertension, former smoker with a 20-pack year history. You obtain radial access and you successfully snare the device. You remove the device, but the patient develops a tearing 10 out of 10 chest pain. You think fast, you had an EVUS on hand, and you can visualize the presence of an intimal flap on the ascending aorta. What is your blood pressure goal? You're going to start esmolol on this patient right away, but what is your blood pressure goal on this patient? We got 2 answers in, 3 answers in. I'll give you guys a little bit more time. And you can keep answering, by the way, even after I get this up. All right, we got 2 answers for SBP of less than 120 and 1 answer for SBP of less than 140. Anyone else want to throw in their answer? I'll give you about 30 seconds. Got 1 more for SBP of 140. Oh, you can change your answer. You can always change your answer if you want. All right, so this is an acute aortic dissection. I'm going to go ahead and lock the answers here. This is an acute aortic dissection, and the goal is actually less than 120. You don't have to drop it less than 100, but you do want to drop it a lot. You want the blood pressure to be as low as possible while still maintaining perfusion, because you're trying to avoid that, that intimal flap you saw propagating any further. So you want to decrease it to less than 120. So if you just have labetalol on hand, again, whatever beta blocker you have on hand, just push it in this case and drop that blood pressure. So I do want to talk about other antihypertensive choices in the acute setting, but I don't want to go through all of them. This isn't even a complete list, and you can see how many of them there are. You can read through this list at your leisure if you want when you're looking over the recorded lecture. But let's just talk about a couple of them that you're probably going to find useful in the acute setting. Hydralazine, most institutions have hydralazine. I'm sure you've seen it at this point. You can give it 5 milligrams and 10 milligrams in a single push. Hydralazine is a great drug. The only cases where you avoid it, as we discussed earlier, are ACS, because it causes reflex tachycardia, and acute heart failure, because again, it causes reflex tachycardia. Other drugs, labetalol, very useful. Most facilities stock labetalol as well, and you can have it on hand. You can have it on hand intraprocedurally even. You can give it 20 milligrams at a time. You can give it 40 milligrams at a time if you really want to, and you can give it multiple times up to a cumulative dose of 300 milligrams. So you can give a lot of labetalol if you really need it. Great drug, flexible drug. Metoprolol, a lot of facilities will also have on hand, 2.5 or 5 milligrams at a time. Not as great for blood pressure. It's very beta selective, very beta valent selective. So it's not as great for the blood pressure, but it will control your heart rate. Esmolol, also super useful. We talked about it. It's very short acting, eliminates in less than 15 minutes in most cases. So it's useful as a drip. You can't overdo it because you can just turn off the drip and it clears very quickly. Nicardipine, also useful, given as a drip usually, useful for refractory hypertension with pushes of, if you've given, hydralazine several times, you've given a labetalol, it's not working, start them on a nicardipine drip and control it from there. That's totally fine. Clevedipine, you've probably also seen in this context. You use it the same as nicardipine. It's a little bit more forgiving, more expensive, but more forgiving. So some facilities won't stock it. Surgeons love this. I've seen some of the IRs use this as well, but shorter elimination half-life of 15 minutes. So you can use it sort of the same way if you're giving pushes of other medications not working. Excuse me. Enalaprolat, another one that's kind of useful, especially for NPO patients. I like using it. If the patient was on an ACE inhibitor previously and they're NPO now, this is actually a drug you can schedule and use it as a replacement for the ACE inhibitor. It's an IV ACE inhibitor. But obviously it's contraindicated in AKI, so that's one of the cases you don't want to use it. Okay, what do you want to do after you push some IV medications and get the blood pressure controlled initially? You want to start the oral medications as soon as possible. So this is a case of hypertensive emergency again. You want to get control of the blood pressure, yes, but as soon as you can, start the oral medications. Those stop the blood pressure from fluctuating. Those also give you a sense of what the patient is going to need on discharge. So current preferred choice of initial medications, again, you're going to see this a couple of times. Chlorthalidone, I don't like using inpatient as much, but it is one of the preferred outpatient drugs. Amlodipine, a dihydropyridine calcium channel blocker, right? You can use amlodipine. Lisinopril, or an ARB, an ACE inhibitor, or an AR, or an angiotensin receptor blocker. Perfect. Good choices. If the patient isn't already on one of these, start them on another, or start them on one of them when you're having hypertension and you want to make sure it stays controlled. Always schedule your medications, especially if your patient's NPO. If you can't do oral medications, schedule your IV medications. Regular pushes of medications are giving you a more stable control than chasing the blood pressure with PRN medications. You can start with a PRN. I have no objections to just leaving, patients' blood pressure is occasionally spiking up. So we leave in hydralazine PRN, but if you're noticing they're needing regular doses of it, schedule it. Don't keep it PRN, give it to them before they need it. Most IV medications will be scheduled like every 4 or every 6 hours. There's some medications that can be converted directly, like beta blockers, and just add up how much they're taking over the course of the day and redistribute over that dosing. There's a couple I'm listing here just for the sake of listing them, really. But if you're not sure if a conversion from an oral medication to an IV medication exists, look it up, or just ask your pharmacist. And if there isn't one that exists, then go ahead and try one of the acute medications that we talked about. Just give them hydralazine, give them some labetalol. No big deal. And yes, if you give them a PRN and they're needing it scheduled, then just schedule it. So I'll give you an example of this real fast. I'll work through it myself, or we'll work through it together rather. If a patient is NPO, they were previously taking hydralazine 50 TID and amlodipine 5. Amlodipine doesn't have a straight conversion, but hydralazine does. It's a total dose of 150 milligrams a day. So if you scheduled it 6 times a day, it would be 25 milligrams Q4 hours. So oral dose is twice the IV dose. So that would be 12.5 milligrams. We have a pretty close dosing there of 10 milligrams. So let's schedule 10 milligrams of Q4 hours and just schedule it. And we'll leave on a PRN as well, just in case the blood pressure goes above 160 over 190. And say you do this and blood pressure is still, spiking up every once in a while, every 8 hours, they're needing that labetalol, then let's just schedule the labetalol. Q4 hours, that blood pressure 140/85, you're not going to tank it with 20 milligrams of labetalol. So let's just schedule it and see what we get. That would be sort of the example of what you do. Okay. This is pretty much everything I have on inpatient management. So let's talk about outpatient hypertension management. This is becoming more important for the IRs as well, because we're managing your own patients outside the hospital as well. Your patients are going to come to you with uncontrolled blood pressure. They come to you with uncontrolled blood pressure all the time. So what are your goals for blood pressure outpatient if you're following somebody up? Well, you want to control with the medications if, in the rare case that they have no comorbidities, their blood pressure is greater than 135/85, but most of your patients are going to have risk factors for atherosclerotic disease. So your goals are going to be 130/80. Your actual goal is 120 to 125 systolic, but this is the limit over which you want to control with medications. And almost all of your patients that you're going to see are going to have a risk factor for atherosclerotic disease, or they're going to have CKD, or they're going to have some vascular disease. So this is the number to keep in mind, that 130/80. And if you can control it more than that, that's great. Your older patients, actually, the ones that are over 65, you can relax this a little bit on, but this is still the ideal goal. If somebody has comorbidities, this is what you're trying to get. Intensifying medications, I'll also talk about briefly. If the patient's more than 15 milligrams of mercury above their goal, it's actually usually better to start a low dose of 2 medications than it is to start a maximum dose of 1. This is also going to be a lot of your patients. A lot of your patients are going to come in with a systolic blood pressure of 150, right? That's already more than 15 milliliters of mercury, above your goal. So it's going to be better to start 2 medications at low dose and maximum dose of 1. And this is partially because it causes less side effects, and partially because you get diminishing returns if you're just intensifying a single drug than starting a second regimen. There's one exception to this. I'll forgive you if you have a very non-compliant patient and you're just trying to get them to keep their medications. Just start them on 1 medication. If it's easier for their compliance and that's what it takes to get them to actually take their medication, do that. It's pointless to start 2 medications if they're not going to take either of them because it's too complicated. So that's important. I'm also going to mention the workup for secondary causes. This has gotten a lot more common over time here, because we used to say if the presentation is unusual for hypertension, right? It's a super high blood pressure, or it's abrupt onset, or it's onset in a very young patient, we should work up for secondary causes. Well, that counts even if the patient is stage 2 hypertension on initial detection. And that might be a lot of your patients. Anyone who's consistently over a systolic of 140 or a diastolic of 90 counts for this. And you want to work up for secondary causes. And you can also work up for secondary causes if physical exam clues or lab clues are present. So if you hear a bruit on abdominal exam, or you see hyperkalemia and you think, oh, I want to work up for hyperaldosteronism, primary aldosteronism, that's valid. And if they're also on 3 drugs, including a diuretic, you can work up for secondary causes. What secondary causes should you work up for? I want you to remember just a couple of them. The most common secondary causes, CKD. A lot of times in IR, you're probably already going to know if somebody has CKD already or not, because some of your patients will come to you with a known history of CKD. If they don't have comorbidities, primary aldosteronism. Renin aldosterone ratio is very easy to check these days, to send out for renin aldosterone ratio. So you can do that. Sleep apnea, another common cause that you can refer out for. If they have any risk factors, even overweight or obesity or history clues, just do it. They don't have to be positive on a stop bang score, just anything concurrent with the hypertension. You can ask them to do a sleep apnea test. And there's less common secondary causes. I'm not going to dive too deep into them, but there's pheochromocytoma and carcinoid syndrome and Cushing's syndrome, other things that you might get things for. But those are the 3 that I want you to remember. If somebody just comes to you with an elevated blood pressure over 140/90, just chest test for those things. All right, preferred medications. We have some mainstay medications for hypertension. Chlorthalidone or a thiazide diuretic. I keep mentioning chlorthalidone. Why do I mention that? Partially because chlorthalidone specifically is a thiazide-like diuretic. It's not actually a thiazide. That's been studied for wonderful cardiovascular benefit. Chlorthalidone has cardiovascular benefit. We like it in hypertension. And lodipine, also studied with cardiovascular benefit in hypertension. So we use both of these medications as our initial medications when we're just starting somebody. ACE inhibitors, I've mentioned, and angiotensin receptor blockers, I've mentioned as well. The ACE inhibitors and angiotensin receptor blockers are great when somebody has kidney disease. So that's in somebody with chronic kidney disease. If they have any signs of kidney disease, we're immediately going to start an ACE or an ARB. So that's why you see sometimes people with just monotherapy ACE, because you have hypertension and you have chronic kidney disease. Do be warned that if they're at risk of precipitating ESRD or they're close to ESRD, you might not want to start an ACE. Because you can precipitate a little bit of a bump in creatinine every time you start it. But in every other case, ACEs and ARBs are great for preventing the progression of that kidney disease. Diabetes, with any kind of diabetic nephropathy, use an ACE or an ARB. You'll also see people with diabetes and hypertension on monotherapy with just lisinopril or just losartan. Congestive heart failure, this is one I just want to specifically mention. Entresto, we actually see bigger drops in blood pressure with Entresto. That's the neprilysin inhibitor plus the angiotensin receptor blocker, sacubitril valsartan. We see bigger drops in blood pressure on that than we do on just an ACE or an ARB. So if they're not already on Entresto, start them on it. Because it's better for them to be on it. Entresto was also recently approved for both heart failure with preserved ejection fraction as well as reduced ejection fraction. So this is one of the things you can keep in mind and actually improve some of your patients' quality of life and just morbidity, mortality by doing. So what if you need to intensify therapy beyond that? Well, if you've already exhausted your mainstay medications, that would include, if they're on 3 hypertensives, antihypertensives, including a diuretic, then you should be working up for secondary causes. So we've already talked about that. So make sure you know your patient's kidney function, make sure you get a renin-aldosterone ratio, and make sure you test for sleep apnea. And if those fail, or you have clues for something else, like they've got a Cushingoid appearance or something, test their cortisol, test for metanephrines. The less common causes are going to come up less, but these 3 I really do want you guys to remember that you can test on all of your patients, and it's quick and easy. If while you're working up for secondary causes, there's some other medications you can use. Hydralazine, you'll see a million times inpatient. Hydralazine is a very flexible drug, up to 200 milligrams a day. Give it in divided doses. I usually like giving it TID or QID because it wears off after 6 hours. You want to make sure that it's split and you're not getting blood pressure fluctuations. You can use beta blockers. Carvedilol and labetalol are preferred for the alpha-1 activity that they have. They have a little bit of crossover activity. Labetalol specifically has no shown mortality benefit in heart failure. So I usually just use carvedilol if I think the patient has any risk of heart failure even in the future. But both of those are there. Clonidine, I don't like clonidine because of the rebound hypertension you can get if somebody skips a dose, but it is there and it's an option. And it's an otherwise good medication. You can give up to 2.4 milligrams a day divided TID or QID. It comes in 0.1, 0.2, 0.3 doses. 0.34 times a day is 2.4 milligrams a day. So remember, clonidine exists. There's nitrites, isosorbide mono and dinitrate, useful in hypertension. That's supposed to say heart failure, not hypertension, apologies. Heart failure and stable angina helps with the anginal symptoms, and it also helps with heart failure just because it decreases the preload, which we talked about a little bit earlier. Minoxidil, another sort of generic vasodilator, kind of like hydralazine. I try not to use the 2 together, but another one that's very flexible. You can give it in divided doses. You can give a lot of it. You can give oral minoxidil. All right. I've been through a lot of information. I've been through it very quickly. After this, I have some practice questions, a couple of vignettes to do. Are there any questions before we get into that? or any bits of information, anything you guys would like me to address directly. We'll take about 2 minutes just to wait for any open questions, but then we'll go on to the practice questions. So take your time, take a water break, come up with some questions if you have any.
Hey, Nitin, it's Lisa.
Hey, Lisa.
Thanks so much for the great lecture so far. One question that I feel like is relevant for IRs is you talked a lot about, I think, primary hypertension.
Yes.
What's kind of your threshold for starting to screen for secondary causes of hypertension, specifically, adrenal, primary hyperaldosteronism?
Yeah. Sorry, you said other than primary hyperaldosteronism?
No, specifically.
Specifically. Okay. So my threshold is actually very low. So these days in primary care, the threshold has dropped. If you have like even if you have a small indication of, let me go back a couple slides here. Even if you have a small indication of hyperkalemia, you can start screening for it. And the threshold has dropped a lot in primary care. I was hoping I'd go back a slide at a time. Just somebody presenting even with, even if they're controlled on 3 medications, but their blood pressure is occasionally fluctuating above 140 over 90, I'll just screen for it. If their initial presenting blood pressure is 140 over 90, or that's their blood pressure without medications, I'll screen for it. That's part of the decreased threshold for screening for secondary hypertension. Is even if they're stage 2 hypertension, and that's anyone with 140, with a systolic of 140 or a diastolic of 90, you can start screening for it. We're finding it's a lot more common than initially thought, right? It used to be, you have to be very hypertensive, like over 180, over 110, before somebody starts working up for secondary causes of hypertension. No, it turns out it's actually a lot more common. So we've really relaxed those standards. Nobody's going to fault you for drawing a renin aldosterone in most of your complicated patients.
That makes sense, because you mentioned hypokalemia as a clue, but it sounds like a lot more patients are being diagnosed before they become hypokalemic, because
yes, yeah,
more severe sequela, I suppose.
Yes, yeah.
Thank you.
Yeah, you're welcome. Let's just scroll down these. Oop, getting ahead of myself. All right, I don't see any other questions submitted in chat or the question and answer feature. So I'm going to go ahead and go into the practice questions here. Okay. So this is a vignette. In fact, all these are vignettes. You have a 72-year-old female with a history of hypertension, type 2 diabetes mellitus, congestive heart failure, colon cancer with liver mets, and she's admitted to your service prior to chemo-embo. She normally takes amlodipine 10 milligrams, sacubitril valsartan 97 over 103, and carvedilol 6.2 BID. However, the day of admission, she skipped both her doses of the medications, and she's been held NPO this morning prior to the procedure. Just before the procedure, she appears slightly short of breath. You note some sparse crackles on lung bases on exam. EKG is not significantly changed from prior, but the chest x-ray shows light opacities in an alveolar pattern, and speech and cognition are normal. Neuro exam is normal. You administer supplemental oxygen, and these are her vitals. Important ones here are mostly the blood pressure of 187 over 100, and the fact that she's requiring 4 liters of nasal cannula to be saturation of 94%. So this qualifies as hypertensive emergency, right? She doesn't have too bad pulmonary edema. It looks like maybe it's just starting, but she has it. So you want to do something about the blood pressure. What do you want to do about it? What's your goal? We got 2 answers in. I'll give you guys more time for the vignettes, so I'll give you guys about a minute here. Four answers in so far. If anyone's still reading the question, I'm going to start giving you hints. So if you're watching this lecture after the fact too, and you don't want the hints, pause. So what's our algorithm here? It's hypertensive emergency, but it's not one of those three conditions, right? That we have strange blood pressure goals for. Those three conditions are ischemic stroke, hemorrhagic stroke, and acute aortic dissection. She doesn't seem to have signs or symptoms of any of those. And she has a pretty clear singular effect that's going on here. She seems to have some hypertensive pulmonary edema. So our goal is going to be in the first hour, a 10 to 20% reduction. So we've got most people answering in, most people answering with A, that's the correct answer, a 12% reduction, somewhere between 10 to 20%. And that's what our goal is going to be in the next hour. Good. Very good, guys. Now, same patient, you decide to administer her usual doses of sacubitril valsartan, amlodipine, and carvedilol. You're going to delay the procedure at this point anyway. She's got some finicky respiratory status. You don't want to do chemoembo right now. So you give her oral medications, and you also give her 5 milligrams of hydralazine. After 5 minutes, the blood pressure hasn't changed much, right? It used to be 187, now it's 184. So you give her another push of hydralazine, 10 milligrams, and within 30 minutes, her blood pressure is now 165/88. That's at goal. Both the systolic and diastolic have decreased by 12%. And she's no longer needing supplemental oxygen. And you get a repeat chest x-ray, and her findings are improved. So you kind of want to keep this patient on your service and complete the chemoembo either after 6 hours at the end of the day or tomorrow morning if her blood pressure is stable. So if you're going to keep her NPO for the rest of the day, just in case you can do this at the end of the day, what do you want to do? Which of the following is the most appropriate regimen? And again, I'll give you guys about a minute to think about it and answer. So we got 4 results so far. This is where I start dropping hints. Remember, I heavily prefer scheduling medications if at all possible and having a PRN as backup. And if you've already given a medication, it's good to use what you've already given as a sense of its effect on somebody's blood pressure. Got 5 answers in. We're coming up on about a minute here. So let's see what people are saying. We've got 1 for starting labetalol and keeping a hydralazine PRN as backup. And 1 for, that's not a wrong answer, by the way. I just asked for most appropriate. So whoever changed your answer, nobody's going to fault you for picking option B. I just like C a little bit better, so I'm pushing it. And the only reason C is a little bit better, in my opinion, is because you know how hydralazine works on this patient and you know that it's effective. It's going to wear off in about 4 hours. So just schedule it. You've also already given her oral medication. So you know that those are going to start to kick in, especially sacubitril valsartan actually kicks in within a couple of hours. You'll get a blood pressure effect. So you probably don't need to hit her with labetalol right now, but nobody's going to fault you for doing that either, if that's what you did. But yes, very good, guys. Scheduled hydralazine, you just need a single dose 4 hours from now. If you're not going to do the chemo embo today, you can probably give her oral medications again. In fact, I think there's a third part to this vignette. There might not be. I might have taken it out. Yeah. All right, different vignette. Different patient. You have a patient that follows you with you in the clinic, seeing you for follow-up, 64-year-old female with history of hypertension, type 2 diabetes, PAD, CKD, obesity, former smoker, who you get into a discussion with her blood pressure. She notes that it's been consistently high, fluctuating between 135 to 85 and 152 over 94. She's also gained 10 pounds since her last visit 2 months ago. She's currently only on one antihypertensive, lisinopril, 10 milligrams daily. In addition to working up any secondary causes that might be appropriate here, what is the most appropriate change to her blood pressure medications? Again, you'll have about a minute, and once I get a couple of answers in, I'll start dropping some hints. All right, we got 4 results in. So your hint on this one is remember that you get diminishing returns the more that you increase one medication. And again, there's an answer here that I think is the best answer, but there are also some that are not wrong. So you're not going to go wrong on this. All right, we're up on a minute, so I'm going to go ahead and move to the next slide. Let's see what people are saying. All right, we got answers all over the board. I like this. So increase lisinopril to 40 milligrams. This is actually, if you know this patient well and this patient is not compliant on their medications, this is a fantastic answer. Because if they're really having trouble keeping up with their medications, you don't want to add more medications if you don't have to. So if you have a non-compliant patient, go for it. Increase the lisinopril to 40 milligrams. But if your patient is compliant and they're going to stay on top of this, and you've already scared them into behaving after you revascularized their foot last month, I would add amlodipine. It's a second agent, and usually you're going to get more bang for your buck, cause less side effects if you add a second agent rather than just intensifying the one you're on. So either C or D is fine. In this particular patient, based on sort of the amount of hypertension, I'd probably shoot for D over C for now. The vignette itself kind of hinted that she might be having some sleep apnea as her secondary cause of hypertension, because she gained that weight over the last month, and that's when her blood pressure has been acting up. So you might want to refer her out for that. But in the meantime, control her blood pressure. Add amlodipine, plus or minus intensify the lisinopril. Very good. All right, so we're coming up on time. Do you guys think we have enough time for one more vignette? I'm going to try to do one more vignette. This is another patient, and then we'll see if, yeah, I'll just do one question here, and then I'll take questions. Another patient. You are observing a patient post IVC filter retrieval. This is a 56-year-old male with a history of CKD, tobacco use disorder, uncontrolled hypertension, DVT, a recent GI bleed. This is inpatient. And he's back on anticoagulation without the recurrence of bleed because you embolize a GI bleed. He has been intermittently hypertensive to the 180 systolic blood pressure and complains that he hasn't had a smoke. Nursing has had to redirect him from absconding twice. The patient suddenly develops a tearing 10 out of 10 retrosternal chest pain. Chest x-ray shows an obvious widened mediastinum, and you confirm the presence of a type A aortic dissection on a stat CT angiogram. Blood pressure is 168 over 100 and heart rate is 92. Which of the following is the best medication to start immediately? This is a very improbable scenario, by the way, but it's one I've seen before. Not this exact scenario, but somebody just post minor procedure, getting themselves agitated and getting a aortic dissection. All right, got 4 results in. Your hint here is, remember, you're not just controlling one vital sign. You actually have 2 vital signs to control in an aortic dissection. All right, we're coming up on a minute, so I'm going to go ahead and see what people are saying. And we have nitroprusside drip and esmolol drip. Most people voted for esmolol drip. That would be my first choice of what to start. Labetalol push is also not wrong. If that's the thing you have on hand, just push labetalol. But esmolol drip is great because you can't overdo it, and you're going to control their blood pressure rapidly and their heart rate rapidly, and take all the stress off that intimal flap. Very good. I'm giving you guys the aortic dissection multiple times just because I like that case. It's one of probably the the nightmare scenarios, like your patient has an acute aortic dissection on you. But I want you guys to be confident that you can start initial management for that for no problem, because it is actually a very straightforward thing to manage medically. You guys get to do the hard part sometimes. So the same patient, you administer morphine and start an esmolol drip. You titrate up until the heart rate drops to 56. Blood pressure is 135 over 76. The patient complains of feeling woozy. He's alert and oriented ×4, and his physical exam is totally normal. What's your next best step? Got 3 answers here. We're coming up on a minute. I'll say that your hint is just woozy isn't necessarily a bad thing. You need to stop that thing from propagating. All right, let's see what people are saying. Add nitroprusside or increase the esmolol drip. Neither of those is really a wrong answer. I would prefer adding the nitroprusside drip in this case, because your heart rate is actually already at goal. It's better to just add the nitroprusside. Don't drop the heart rate anymore, just drop the blood pressure. Very good, guys. I do have more questions, but we're coming up on time, and I want to leave a little bit of time for questions just in case anyone has them. So we won't do any more questions here. Any questions? Comments?
Just want to say thank you for that excellent presentation, Nitin. You know, I learned a few pearls myself, and I think it was very valuable.
Awesome, you're welcome. Appreciate it.
Definitely. Thanks for putting all of this together, Nitin. I'm looking forward to the next webinars in the series.
I am too. I appreciate you guys. Oh, wait, hold on. I think I've got one question under Q&A. Oh, just a thank you. Okay. Awesome. I usually make the mistake of ending too quickly, so I will give it another minute just for any other questions to come in, but then we'll wrap up and call it a day. Thank you guys for coming. All right, not seeing any questions. Have a good night, you guys. Thank you all for coming, and I'll see you guys at the next one.
Thank you so much. Have a great night.
You too.